Good afternoon, everyone. I am Kristina Talbert-Slagle, Assistant Professor of General Internal Medicine and Associate Director at the Yale Institute for Global Health and the Yale School of Medicine. I am delighted to welcome you to the Yale Institute for Global Health Conversation Series, a venue for our community to learn from and connect with innovative leaders in global health. Coming from diverse backgrounds, our invited guests will introduce us to cutting-edge work in global health, including research, implementation, policy, and many other perspectives. In addition to the Yale Institute of Global Health, we are indebted to the George Herbert Walker Jr. Lecture in International Studies at the Whitney and Betty McMillan Center for International and Area Studies at Yale for co-sponsoring this series, including today's event. Today, I am pleased to be joined by my co-moderator, Dr. Onyema Ogbuagu, Associate Professor of Medicine and Director of HIV Clinical Trials at the Yale School of Medicine. Welcome, Onyema. It is great to have you with us today.
Thank you, Kristina.
And now let me introduce today's distinguished guest, Dr. Bernice Dahn, the former Minister of Health in Liberia and current Vice President for Health Sciences at the University of Liberia. Dr. Dahn is renowned for her work rebuilding Liberia's post-war healthcare system. The Second Liberian Civil War from 1999 to 2003 decimated Liberia's health infrastructure and compelled many of its health workers to flee. As Deputy Minister for Health Services and Chief Medical Officer, Dr. Dahn was integral in bringing an end to Liberia's 2014-15 Ebola outbreak. She developed treatment and infection prevention protocols, organized training, mobilized resources, and restored routine health service delivery, critical steps that likely saved thousands of lives. After Ebola, as Minister of Health, Dr. Dahn created a 7-year initiative to improve and expand the public health workforce, and she developed with partners Liberia's first national cancer control strategy. In her current role as Vice President for Health Sciences at the University of Liberia, Dr. Dahn spearheaded the critical revitalization of medical, nursing, and midwifery schools, creating a new educational and training pathway for healthcare professionals in the country. Welcome, Dr. Dahn. It is an honor to have you with us today.
Thank you, Kristina, and good afternoon to everybody. It is good to connect once more with the US community and everybody who is on this in this session. I hope that we have been able to cope well with COVID and we can move our lives forward. We would also like to congratulate Onyema, who is working seriously to support some of the COVID prevention activities, the vaccine production trials, and we are looking forward to results from there so it can put us at ease. Again, welcome to everybody, and I am here to listen and answer your questions. Thank you.
Thank you so much, Dr. Dahn. So Onyema and I have prepared a few questions. We also welcome questions from the audience. Please put them through the chat, and we will look forward to sharing them with Dr. Dahn as we go along in this conversation. So Dr. Dahn, let me just start by asking you, can you speak to how you approached the concept of systems rebuilding in a post-crisis setting? Was that response different for different types of crises, such as a pandemic versus a civil war? And how did you achieve political buy-in for the response?
Okay, thank you, Kristina. Liberia's healthcare system have been repeatedly challenged by crisis. So from the Civil War, the Ebola, post-Ebola, and now COVID. Rebuilding for Liberia has been in two folds, from the crisis and then the setbacks that was caused by the Ebola outbreak. In any of those situations, strong government leadership is very important. There's a need for a well-defined and well-articulated vision. The vision cannot be in your head for the entire country. So it has to be documented and it has to be accessible to everybody, including the locals, those who it will benefit, all the different stakeholders, including those who will support you to implement them. Now, in the Liberia context, and I've seen this globally also, when there's a change from one government administration to another, it is a perfect opportunity to articulate visions and position, especially if you are working in a sector, to position the sector's vision. Because at that time, the government and all its partners and well-wishers who will support the government to grow are looking for looking up to the government for leadership, for them to make decisions. For example, normally the government will be defining their 90 days deliverables, 150 days deliverables, and that is a perfect opportunity to articulate, to use that timing to position the sector. So the Liberian health sector at the time took advantage of that. And at the time coming from war, the human resources were not there, but we also had partners who were on the ground who were also supporting the government during the emergency phase and was looking up to the government during the rebuilding process on roles that they could play. So we leveraged that partnership using both the resources, human and financial, to develop our first national policy and strategy. So the policy and strategy was co-designed with the government in the leadership. The government, it is important to emphasize that the government have to provide true leadership for ownership. And so with that, first, it helped to build confidence between us and the partners. But more importantly, because the policy and those instruments were co-designed, the partners also positioned themselves as to how they can help the government to deliver things that we all agreed on in there. Remember, Liberia is a resource-limited country. The entire government budget is less than 600 million up till today's date. The Ministry of Health or the health sector budget for most time range between 12 to 14% of the total budget. About 70 to 80% of that budget pays health workers' salary. And so there was like not much left to even start building the systems that you are there to build. So there was a need to work and leverage partnerships, both local and international, to be able to deliver the strategy and the plan. So that means we developed a framework within which we were going to work. The Ministry of Health also developed some financial planning tools for the health sector. So in developing those tools, remember that we're coming from war. Most of our professionals have left the country. There were very few persons in country who knew what to do. So again, we co-designed those tools, the financial planning tools. So the plan itself was costed. Costing the plan helped to build additional confidence partners knew, and even the government knew at least how much it was going to take to deliver the plan. And so that helped for people to mobilize the resources and plan to support its implementation. The tools also help to map donor support. So we were able to map who the donors were in country, where they were supporting, and what they were supporting. And from the initial stages, you could see clearly there were overlaps, duplications. And at that time, the donors were supporting the implementing partners directly. So with the resource mapping tool, we engaged the donors. We were friends now. Remember, we designed the plans together. So we were friends, and we had to come back together to ensure that what we all put in the plan, we were supporting that. So we used the resource mapping tool to do geographic redistribution of the resources. So we negotiated with the donors to support where we think we had serious gaps and we needed their help. And so that was done. And that helped to bridge some of the equity gap also. Now, that system was moving on well. I believe we all know that Liberia was able to achieve the under 5 mortality reduction, the MDGs, within 3 years before the end date, even though we started 6 years late. Then we had the Ebola outbreak. The Ebola outbreak, the scale of the outbreak overwhelmed us. Before the outbreak, in the initial plan, we had a unit designed to respond to emergencies. And so whenever there was like measles outbreak, yellow fever outbreak, we sent a team to the county to support them. With the outbreak of Ebola, because we were all working together, we had a coordination forum that met quarterly, and another technical working forum that met monthly. We called the donors back, and together we redesigned the emergency system. So the IMS, the Incident Management System, was established. Emergency operations centers were established in the counties, and they were supported with the things that they needed. The surveillance system was established also to respond. These systems that were developed in response to the crisis transitioned to more permanent institutions or procedures with increasing stability. And so the systems we established during the Ebola outbreak, we transitioned it into the National Public Health Institute with all its appendices still functioning. And it functioned, so it had the main responsibility of identifying diseases that had epidemic potential and responding to them. And so you will realize that during the outbreak, we had to reactivate the routine healthcare services. And then we had the emergency system. The two coexisted at some point, and that's the system that is working now. So with COVID, the outbreak of COVID, it was very easy to reactivate the emergency, the IMS, reactivate the EOCs in the 15 counties. The surveillance team was also already functioning, so it was a matter of increasing surge capacity. With the COVID, the team already knew it is a disease of epidemic potential, and looking at our situation, it was necessary to isolate people who were infected. Everybody who was infected was isolated and treated in the treatment unit. everybody who was a contact was isolated and monitored for the 14 days or so before they were discharged. So building the systems, the approach was not too different. The strategies, policy, even in the emergency, we develop plans and strategies. We align the partners and all those things were co-done. The implementation, so we use the partners based on your comparative advantage. So if you were a donor, you supported the donor coordination and things that we needed to implement, we needed to help to implement. If you were an implementing partner, you supported the county health team where you were with the emergency operations center and all the way down to the community level.
Thank you, Dr. Dahn. Again, always nice to talk with you. So, I want to follow up on that question. So, we do know that while rebuilding health systems, it's really important to consider human capital. And we know Liberia has significant healthcare workforce shortages. It had the inglorious position of having some of the lowest ratios, of healthcare workers to population in the world. Due to, and also exacerbated by some of the crises you mentioned earlier, the civil war and the Ebola outbreak. So, my question to you is, how do you address rebuilding the healthcare workforce? And, having known of some of your work, we'd love to hear also about the medical and health sciences educational programs that you've initiated to address the pipeline for healthcare workers.
Okay, thank you. The vision to develop a fit-for-purpose health workforce was articulated well in our investment plan for building a resilient healthcare delivery system after the Ebola outbreak. So that vision was a part of the overall national vision from the beginning. So during the outbreak, we first of all, we remember that we were coming from crisis. We hardly had the health workforce, and then health workers died during the outbreak also. So there was a need to actually look at how we build the workforce. And normally we do these things, everything is underlined by an assessment, so it's informed by data. So we first did an assessment. The assessment informed us on the health workers that we had in acute shortages and those that health workforce that we needed to improve quality. So if you take the physicians and the midwives, for example, the findings were for us to improve quality, expand the skill mix, and increase the numbers as compared to the nursing, where the finding was and the recommendation was for us to improve the quality of training and increase the skill mix. So with the strategy, with the assessment, we decided to develop the strategy. And this time around, we came across a strategy that was similar strategy for Rwanda, that a partner in country helped Rwanda to develop. So we engaged that partner, and that is YIGH, to see how they could help the Ministry of Health to design the health, to bring all the other partners on the table to design the health workforce strategy. So that went through a similar process like the national policy and plan. So we engaged all the stakeholders around the table. We presented the assessment report, and we used the report to develop what we call the health workforce strategy. Now, with that strategy, the strategy was also costed. And so we engaged the partners to support the strategy. they were on the table to develop it. So a group, they had already positioned themselves on how they were going to support it. So USAID, for instance, decided to support the mid-level trainings that we had in the strategy document. So they supported GPICO and some other US-based NGOs to work with those training institutions, midwifery, nursing, to relook at the curriculum, to look at the training resources, the faculty, and the systems that will help to build the education systems for the health workforce. So they did that for the mid-level cadre. Then we engaged the World Bank. At the time, we were seeing the decline of the Ebola cases, and we had the Ebola resources from the bank. And so we engaged the World Bank to reprogram the support to support the health workforce strategy. And because they had a strategy, which was the instrument that defined the government priorities, they agreed they were going to support the medical education. Now, the medical education in that strategy was in two folds. The undergraduate program, which did not shut down during the war, but the quality was compromised significantly. And at the time, it was graduating like 12 persons per year. And we needed to scale up the numbers. Then we did not have the faculty to teach. The few physicians who were in country were the ones doing the teaching and doing the clinical work. And so that also helped to compromise the quality of the training even further. And so we decided, and then we didn't have the residency training at all. So at that time, the assessment report, I don't think we even had 10 specialists in country for any of the specialties. Even if you put all the specialties together, the sum total was not 10 persons. And so the World Bank decided to support the medical education. We initially set up the Liberian College of Physicians. We set up the Liberian College of Physicians and Surgeons because we decided the training will follow the West African model. And in the West African model, the basic medical training is with the university. So that remains with the University of Liberia. And the residency training is under it could be directly under the West African College or a local college. So we established it under the local college and asked the West African College to monitor so it can be linked to the West African College model. So we did that. Then we built partnership with, first we decided to recruit faculty. And so the LCPS, the Liberian College of Physicians and Surgeons, recruited the first set of faculty. For the first year, there were challenges because once you go on an individual basis, after the first year, then they put their cards on the table. Salaries they felt were low, and they started negotiating, and that was also a problem for us. So then we decided to switch to engage institutions instead. So build partnership with training institutions, universities. They help to recruit for us from within their network. That way we don't have to deal with individuals, we deal with institutions. And then they can deal with the individuals. So we did that. Then most of the institutions that we built a partnership with were US universities. We tried the universities within the region, but they were not as organized as it is with the US universities. And some of these US universities were also supporting other universities within the region. So they already had the platform. So we negotiated with the US universities to recruit people from the region since the curriculum is from the region. So they agreed to that. And so the recruitment of the faculty, most of them came from the region, except where we needed maybe subspecialties. Sometimes they brought in faculty members from US universities. The beauty of that relationship, faculty members were recruited to come and teach in an institution where we didn't even have the equipment to teach. So the US universities positioned themselves to mobilize the resources to help to teach also. An example is we had one of the universities was responsible to recruit faculty to teach surgery and to do pathology. We did not have a pathology lab. We brought in a pathologist and there was no laboratory to teach. And so Mount Sinai, who was responsible for that, actually worked on mobilizing equipment and supplies to set up the pathology lab. And today we have a modern pathology lab. Now, we also do not have the capacity for curriculum development. There are very few, 1 or 2 persons in country. For the undergraduate program, we decided we were reforming. First, we recruited preclinical faculty from the region, since the clinical faculty share with the residency training program faculty. So the faculty from the region are still with us, and we decided we'll reform the medical school curriculum. Reforming the curriculum, we are not curriculum experts, but we engage the institutions, the partner institutions, to assist us with the curriculum reform. And they consented because they work in institutions that have units that look at their curriculum. And so they work with us and their curriculum experts to reform the curriculum. So we divided our teams in departments. We do the work, and weekly we have a Zoom meeting to discuss the work we have done, and they gave in their inputs, and that curriculum is coming on well. Now, currently the medical education is a 4 years undergraduate, and then a 5 years medical training. So you do a BSc first in the biology, chemistry, or zoology, and then you enroll into the medical school for another 5 years, which is 9 years. Liberia happened to be the only country in the region that has a 9-year training program. Others are 6 years. So we decided to reform the curriculum to a 7-year curriculum. It should be an integrated curriculum, competency-based curriculum, and that is being done well. Now, in the curriculum development process, we know that the university processes have to approve. And one big concern in country is that the sciences from high school is weak. We decided to do a 7-year curriculum. So it's a 1-year pre-med and a 6 years medical school. A 1-year pre-med, 3 years preclinical, 3 years clinical. We know that if that curriculum goes to the academic coordination committee for approval, their first question their first concern will be students coming from high school have a deficiency in sciences. During the war years, there were no science teachers. So that has been a very big gap in the training. It is now that the Ministry of Education is building the sciences gradually. So we decided to build in that process a science camp for high school students. So we'll do that 2 years before they enter the pre-med to make them more successful in passing the exams, and then make them more successful in pre-med and the medical school. And that will help to reduce attrition rates also. At the moment, the rate is high. Sometimes we start with 60 students, and by the end of the 5 years, you have like 35.
Okay, thank you, Dr. Dahn. I just wanted to make sure that I didn't step over you. That's fascinating, and it's wonderful to hear you talk about all this work that we have the opportunity to do in some ways in partnership with you. I wanted to pivot a little bit because we have noticed, you know, of course, in Liberia, there's an observable contradiction in the status of women. We see some women like yourself in high positions of authority, very strong leaders, but we also know that there's much gender inequality throughout the system, with high levels of gender-based violence and disparities in education for women and girls. Liberia's healthcare workforce also has gender inequity, particularly in the higher paying jobs and positions of leadership. This problem is certainly not unique to Liberia. We face the same challenges here in the US and globally. But I wanted to ask about strategies as you're thinking about the educational pipeline, health workforce development. What are you using to improve gender equity in Liberia's health systems?
Thank you, Kristina. It is true that women in Liberia have held high positions in leadership, have occupied positions in leadership. And it is also true that gender inequity is also high in Liberia. The first thing is the culture. We grew up knowing that we live in a male-dominated world, in a male-dominated society. Women have defined roles. And so the women themselves also think certain jobs are for men and it is not for them. The previous administration under Madam Ellen Johnson Sirleaf did a lot of work promoting female leadership. That is not the same with the government we have today. There were more females in leadership position in the previous administration compared to the current administration. The previous administration, the females in the previous administration also had more voice in leadership compared to the administration today. So how can we avert that for the future? At the moment, we are designing programs with some of our partners. And the program is to be able to use policy to make decisions. And data to make policy decisions. Normally, if you look at the different levels of governance in our country, if you take the lawmakers, for example, often what you will hear from them is decision-making is numbers. So for them, they vote. And there are very few women in there, so their voices are not heard. And then the way I see lawmakers doing their voting too is, I'm supporting you today because when my time comes, you will have to support me also. Then that's the politics. When it comes to the executive, it's more of leadership. how can the women provide leadership to make policy decisions that will affect women more positively and promote women's leadership. And so in our trainings moving forward is to design trainings for professionals, for policy makers, and will specifically target more women to do that training. So we'll be able to build the skills that they need to network, advocate, and maneuver their ways in society. So we purposefully designing the program to target more women and people who are at more disadvantaged as compared to just leaving it open. Sometimes you design the program without the gender, thinking about the gender perspective. In the design of this program, we look at data from GIZ, one of the partners on gender in the health sector. And we realize that all the M&E officers in the 15 counties are males. There were like 3 different positions that they were all males. And then I just reflected and I said, but they started under my administration. So then I began to think, how did this happen? But the design of our project did not emphasize the gender inequity and how to address them. And so thinking loud, maybe the M&E officers, knowing that we work in an environment where that is very challenging, you have to move from, most of the time they use motorbikes to reach the places. So maybe the recruitment subconsciously took that into consideration and taught on people who will be able to ride motorbike to reach so they have facilities. But you can train women to ride motorbikes. So why we didn't do that in the first place? So we will purposefully design our programs to empower women to be able to hold some of these positions and to be able to do the kind of work that we normally think only men can do.
That was great, Dr. Dahn. And, I think, one of the things I've been pleasantly observing in Liberia is just how there's much freedom of speech and people feel very comfortable airing their views, even in the position to people of power. And I hope that, we can continue advocacy for the rights and status of women in Liberia. I have another question for you before we try to tackle some of the Q&A questions. So I know that the healthcare workforce program, which you helped design and implement, relies heavily on external support, both funding-wise and partners, like you mentioned. But I think one thing unique we've done in Liberia, which you somehow touched on, but would like you to expand on, is how we've had support from within the West Africa region. So countries like Nigeria and Ghana, and how they've provided really valuable technical support and resources to Liberia's health systems and medical education. So what are your thoughts around the advantages of this regional model, where countries within the region support each other, and also given that they share similar limitations and lack of resources?
Thank you. Like I said in my previous statement, the program was designed based on the West African model because we live in the region and we have to also link to what is happening within the region. The design itself, we pay visits to universities within the region also. We expressed our vision to them, and they also decided they will help us. So the advantage of having the West African college faculty members to do the training for us is that the curriculum is similar, the work environment is similar, and they can navigate very difficult situations as compared to if you bring somebody from the West who will have everything available to them. And will not be able to work in your setting where most things are lacking, as compared to someone who went to school in Ghana or Nigeria, who did not have so much sophistication. The situation is virtually similar. They know how to be innovative and get things done. And they will be able to use the limited resources that are available to teach the way they learn it and to be able to impact the knowledge that you want to have. And at the end of the day, it ends up with the same results. So that is a very big advantage. And because we have the West African College, you will realize that our performance also in the West African College exams for membership and fellowship is also very good. We've had situations where our members went, like surgery this year, all those who went for membership exam pass, all those who went for primary exam pass. We've had situations where all those who went for pediatrics pass in the past and things like that. Because the faculty members know the terrain, they know the situation, and so they adapt their training to the real practical realities on the ground.
Thank you, Dr. Dahn. So we'll pivot and take a question from the audience here. Someone is interested in how students are recruited for the science camp that you were describing earlier.
Okay, thank you. The students are not yet recruited. That science camp will start 2021. But we will be recruiting from the 15 counties. Initially, we had engaged the Peace Corps because they were in country and were teaching in the 15, they were teaching sciences in the 15 counties. And so we will work with those who are the trainers to identify the best science students. We will purposefully ask them to prioritize females, and we will recruit them into the camp for training. So we will bring them to a central location for the vacation period and build the kind of skills, teaching them and building the kind of skills that are required for medical school, critical thinking, writing skills, and those kind of things, in addition to the sciences that they are learning in the schools.
Thank you, Dr. Dahn. There's actually a very fascinating question I'm going to throw at you from the audience. We've focused on building health systems, and one aspect of that is that people should have trust in the systems, that they can receive adequate care, and also trust in what health authorities, which are very, very critical, particularly during a pandemic. So someone's asking a naughty question, and that is, what advice would you offer the US regarding rebuilding the trust of the public after seemingly contradictory messaging during the COVID-19 pandemic? So this is all about messaging and rebuilding trust. You know how in the US, and loss of faith in systems kind of impact people's willingness to adhere to public health measures, take a vaccine if it's approved. So given your experience as the Minister of Health of Liberia, what advice would you offer us about how ways to rebuild the public trust in our systems?
Okay, thank you. Loss of public trust, especially during the pandemic, the US is not the first. During the Ebola outbreak, a similar thing happened in Liberia. The public did not trust we had Ebola, and so they did not have trust in the government. People believed that the government was making up stories to get more donor funding, and so they did not adhere to the health instructions that were coming from the Ministry of Health until Ebola overwhelmed us. The communities took upon themselves after that to organize themselves to address the issues from the community level. So they were the ones doing the carrying the health messages. They were the ones who were identifying the cases for isolation. They were the ones who were mobilizing resources to support family members and communities who family members got affected. That model is what we took. We revised our community health strategy and policy, and that is what we are implementing now. Now, what I've realized with the outbreak of COVID-19, the Liberia scenario and the US scenario, my own perspective is the not using data for decision making. The technicians are there. The US government, and that's the interesting thing about it, was the key partner who helped us to establish the incident management system, the emergency operations centers, the surveillance systems that we have in place today that is addressing the COVID issues. What I see with the US, those systems are there. Their routine healthcare systems are there. The emergency systems are also there. The difference I see here is they help us to decentralize our system. And so today, the county health teams respond to emergencies. They start responding to emergencies before the National Public Health Institute goes to assist. And I think that is the difference with the CDC sending teams to states to help. Another thing I see is the politics. The politics, the government, and this happens with the government. It is so sad to say that politicians will use their population to remain in power or to gain popularity. The technicians are giving information and giving guidance, but politicians want to hold on to positions, want to be seen as working, and so they leave all the data aside and they follow the politics. As a result, things are not working as it should work in the US. That's my own analysis. That also happens here in Liberia sometimes. The politicians will take things. We have had hospitals that were built in the past because a politician wanted that hospital in their village. There's a hospital in Cape Man that no one patient never entered one day, a very big structure, only because a politician wanted recognition. The politicians have to listen to the technicians. They have to work together in the interest of the population and not for themselves. Thank you.
Thank you so much, Dr. Dahn. It's very powerful. So we have just a few more minutes. Wanted to ask you, we have many individuals, including students in the US, in Liberia, all over, who are passionate about the issues that we've been discussing today and who want to engage in this kind of work after they graduate. And I wanted to ask, what would be your advice for them, competencies and skills you think they need, or how you would advise them as they go forward in their own careers?
Thank you. My own scenario, I was a mid-level professional, so I graduated from medical school. I worked in a hospital for some time, and at a certain time, I went over to the ministry as a director with all leadership skills, with all management skills. And I still did the clinical work alongside the ministry work, the public health work, until I went for my training for my MPH at the University of Washington. That training had a component that focused on leadership and management. In addition to all, even though leadership and management was built in all the topics, even in the church, I heard that, but there were specific sessions on leadership and management. And because I had practical experience prior to going to school, it helped me to map out where my shortcomings, what my shortcomings were. So it reshaped the way I work and the way I think. It helped me to develop advocacy skills. It helped me to learn how to network among partners, my supervisors, leaders to get things done. So even if, take for instance, if I have a boss and I have a vision that my boss is finding difficult to, I can actually get to another person who I think my boss will listen to, and that person can help to position my vision for me. Communication skill is key. You must be able to articulate your vision. You must be able to think strategically and must be able to think ahead. That way you are able to position things, you are able to navigate the system to be able to get things done. You must be able to know who are your stakeholders. You should know who can help you to be successful and who can help to break you and how you can bring them together. You must be innovative. You must be thinking ahead of the work. So those are some of the things that actually helped me. And I actually learned that after some years of practice, went back to school, I was able to clearly define what I was doing previously and what I think I could do moving forward. Thank you.
Thank you, Dr. Dahn. I think it's always just inspiring to see how you've climbed through the ranks and really left a footprint at all different levels of the health system. So I just have one quick question. We have just 6 minutes before we close. So before I hand off to Kristina to give a closing statement, I couldn't resist asking you one last question. So, we have current challenges, including COVID-19, and you've showed leadership during the time of Ebola for your country. And so I would just like you to, in the next 2-3 minutes, just, share with us your thoughts as to what you think are the next big challenges for global health in the next 5 to 10 years. So both within the Liberian context and maybe US context, we see, for example, for infectious disease like COVID-19, how our destinies are tied globally, and that we really have to work together to confront some of our biggest challenges. So what do you see in the next 5 to 10 years as being the future global health challenges?
Well, pandemics will always be with us. Just how we are trying to solve the problems with disease outbreak is the same way the pathogens are strategizing to challenge us with new outbreaks. And so as we design systems, we should remember that we need to design the systems. Yes, emergency, you respond to it, but think long-term, because you will always have an outbreak that you will have to respond to. At least in my lifetime, I've seen HIV, bird flu, mad cow disease, COVID-19, Ebola, I've heard some, I've seen some. So it's like we'll continue to have outbreaks. And so building the systems is key to managing both the routine services and the outbreaks. So there's a need for us to not to give up on building the system. Once the things return to normal, we forget, and then we go back to our regular routine. We should always have the systems to be able to provide routine healthcare services and be able to respond to emergency when there's an outbreak. Another challenge is the is non-communicable diseases that is also growing gradually. Somehow in the developed world, it has been there for some time, but in the developing world, it is growing. And for us in the developing world, to manage these things is expensive, so we need to think on preventive seriously. So those are the two key things that I think we should look into moving into the future. Thank you.
Thank you so much, Dr. Dahn. And for that answer, for this fantastic conversation today, for taking time out of your very busy schedule to join us. It's such an honor to have you as one of our conversation series speakers. I also want to thank you, Onyema, for co-moderating with me. It's wonderful to be doing this together. Thank you so much. And I would like to thank the audience for your engagement and your insightful questions. It's just been wonderful to have everybody together today. Thank you so much. And with these remarks, we are concluding our 2020 Yale Institute for Global Health Conversation Series. Thank you all again for joining us today, and we wish you a safe and joyful holiday season and a happy new year. Thank you so much.
Thank you, and thanks to all of you. I hope I was able to meet your expectations. Thank you.
Thank you so much.
Thank you, Dr. Dahn.
Bye-bye, everybody.